Now why 3D? In a 3D, because you get a wider coverage and you get a higher SNR, because acquisitions are done over the same area repeatedly, so you get a higher SNR, wider coverage. And post-processing, it is excellent for post-processing because you can separate, in case of venous contamination, you can separate the artery and the vein. And also in a case of tortuous vessels, you can follow the signals and you can reconstruct the artery very well. So you have to do a 3D sequence. Now certain technical factors one should understand and know how the image qualities are influenced by these factors, so that you can modify your studies or your equipment depending on the studies required. For example, the TR. The TR should be very low. Why? Because the acquisition time depends on the TR, and if you increase the TR, the acquisition time also will increase. So you reduce the TR as low as possible along with the TE. So how do you reduce? One is if you have a high performing gradient, then the TR and TE of course will be reduced. Then you adjust with the bandwidth. You adjust the bandwidth so that if you increase the bandwidth, the TR and TE can be reduced. But if you increase the bandwidth, what happens is the SNR will go. So you have to adjust the bandwidth in such a way that you can achieve a TR of somewhere around 5 and TE of somewhere around 2 to 3. So if you achieve that TR and TE with a reasonable bandwidth, and preferentially you should use a narrow bandwidth. But if you use a narrow bandwidth, the TR and TE has to be increased. So a intermediate bandwidth may be used. And in plane and FOV you can adjust, and phase of FOV you can either use a rectangular FOV. When you acquire the images in a rectangular FOV, what happens is there can be oversampling error of wraparound artifacts. So one of the advantages of phased array coils is the peripheral signals are low. So in practical sense, you may not always see the wraparound artifacts. So I think you can always use a rectangular FOV, and also you can use a half Fourier acquisitions like 0.5 or 1.5 acquisition. And flip angle, again, if a flip angle of 20 to 40 is the ideal, 30 to 40 is the ideal acquisition. But if you are doing a venography, then it is better to use a lower flip angle. And when you are imaging a stent, then you have to use a higher flip angle, somewhere around 70. So if you know these factors, then you can adjust these factors according to your clinical situation and get an excellent image. I'll show some of the cases which I have done in the last 6 months, and I hope the image quality should be good. If they are not up to the standard, I think maybe I would have injected in the left hand. So let us see, this is a first case where you can see a mid-thoracic infrarenal stenosis, very well seen with the angio. You can see that. And this is a case which has come, they didn't have any details about the surgery done earlier. You can very well see the bypass surgery done here. Sorry. So, in fact, the right limb of the graft, this is an inverted pantaloon sort of surgery. In the right limb is obstructed. You can see the right limb is not seen, whereas the left limb is very well seen. Right limb is not seen here, sorry. So left limb is seen very well. So there is an obstruction, but if you see the image on the left hand side, you can see the collaterals reforming the vessels very well. Even the distal flow is excellent, and you can also see the superficial epigastric collaterals reforming the femoral and the distal vessels. So you get all the information from doing an MR angiography. This is a 12-year-old male patient with 2 aneurysms. You can see the intra-abdominal and lower upper thoracic aneurysms, probably due to connective tissue disorder. In atherosclerotic dilatation, diffuse dilatation of the aorta. Again, diffuse dilatation of the aorta involving the entire ascending arch and the descending aorta. Aortic aneurysms. This is again a young patient, 26 years. You can see the angio which is showing irregular narrowing of the thoracic aorta. These are the axillary renal arteries. So it's most probably a case of aorta arteritis. An occlusive vascular disease with occlusion of the popliteal artery can be very well seen, and bifemoral occlusions. You can see the bifemoral occlusions, bilateral occlusions in the adductor canal. You can very well see the occlusions. And what the vascular surgeons want is the distance between the occluded segment in order to plan for the surgery or for the stenting. This is one case which I would like to show. You can see the venous contamination. So initial days we used to get a lot of venous contaminations. Then if you see the literature, they advise the tunicate at the mid-thigh or at the calf. So we tried with both techniques, and we could not, sometimes it was very difficult, especially in a diabetic foot where it is hypervascular. Very often we see venous contaminations. So what we are doing now is actually we keep the tunicate just above the ankle, and we found there is excellent results without any venous contamination. You can see on the left and right, of course, two different patients, but nowadays with the tunicate just above the ankle, we are not getting any venous contaminations. I think it's an excellent technique to keep the tunicate just above the ankle. This case was for evaluation for a venous angioma to rule out a venous arteriovenous fistula. You can clearly see some enlarged vessels, but these were not actually arteriovenous fistula. These were just venous malformations, which we could see when we rotated the images. So we could image the entire arterial system using our MR. Renal arteries, we have only limited experience because our nephrologists and the transplant people, they are more used with the cardiac CT angiographies. They are asking us whether you can reproduce any images almost equal to a CT angiography image. We are trying, and we showed few cases. They are telling it's getting improved, but not up to that, which is we are still working on that. But transplanted kidneys, there are cases which become, especially when they have any doubt about stenosis in the transplanted kidneys, renal arteries. So we do quite a lot of cases for transplanted kidneys. Time resolved techniques, no techniques which are already discussed. Time resolved techniques, one advantage of time resolved technique is if you have a time resolved technique, you can use it in areas where you expect venous contamination, or in areas where the acquisition or the flow is very fast. Suppose like you want to see the carotid arteries, and the time you get is 2 to 2.5 seconds. So there can be always a venous contamination when you do angiographies of the carotids or when you do below knee. So if you have time resolved techniques like twist, you can use those techniques in areas where you are expecting. So suppose in a peripheral angio, what you can do is you can do routine imaging up to knee, and below knee you can continue with the time resolved technique. So if you have that technique, it's extremely good. And the other important advantage of time resolved technique is it gives a dynamic information about how the collaterals are getting filled, which you will not get from other routine imaging. So dynamic information about the collaterals or shunts, which you get by doing a time resolved technique. I think it's an excellent technique. Now this is just one slide. Is quite often a confusion which modality to be used. I am for MR angiography because I don't have a CT angiography, but I prefer two aspects. One is there is no radiation. It's one of the major concerns of public now, and you get a high resolution. High resolution in the sense it's not a spatial resolution, it's a temporal resolution. So when you have twist or whatever name somebody calls, then you get a high temporal resolution which can be used to evaluate AVMs or shunts or areas where you have venous contamination problems. So the temporal resolution of MR angiography is higher than the CT angiography if you have twist or time resolved techniques. Then vessel calcification, one of the areas. Even though CT can pick up calcification better, it is a disadvantage in peripheral angio because most of the cases are diabetic foot, and in diabetes almost more than 50% of the vessels are calcified. CT angio has a definite limitation in interpreting peripheral angio disease. So MR angio is definitely going to be the investigation of choice for diabetic peripheral vascular disease. New non-contrast techniques have been already discussed. I think I'll skip this. Anyway, this particular slide I just kept because this is a users meet and many of you are entrepreneurs or going to become entrepreneurs. I think this MR angio has a tremendous commercial potential, because what I found is the total acquisition time for a contrast enhanced MR angiography is 4 minutes, and the patient coil positioning may take around 3.5 minutes. So in 7 minutes you can complete the entire evaluation in 7 minutes time, which is much less than a routine brain study with contrast. And our charges are much higher for a contrast enhanced angiography compared to a routine MRI. So I think you are not losing any time, and at the same time you are getting an income. The other side is there is an increased use. You are going to see more and more cases of peripheral vascular disease, and there is a huge potential for optimizing your technique for doing a better MR angiography.